A very good Monday morning to you all. As part of lecture series on sarcopenia, I will be presenting today on role of myokines in sarcopenia, which is one of the most evolving area from last 1 decade. So this is the brief outline of my talk, which I will be trying to cover in next 25 minutes, and starting with definition, mechanism of sarcopenia, followed by types, functions, role of myokines in secondary sarcopenia, what is the connection of exercise with myokine, therapeutic strategies, and finally ILBS data on liver muscle crosstalk via myokines. So let's start with what is sarcopenia, which Dr. Jaya already discussed in the last lecture. To prime again, we know physiologically we lose almost 1% of muscle each year till the age of 70. Then this percentage increases to 1.5% and thereafter. However, in liver disease condition or cirrhosis, which is the secondary sarcopenia, this rate is more than 2 to 3 times, and the loss, which is more than 3%, increases the risk of mortality, which is unrelated to severity of the disease. So according to the new definition, sarcopenia is the loss of muscle mass along with strength and muscle function. Now it is more clearly with 3-step definition. If it is a probable sarcopenia, it is diagnosed on contractile strength. We confirm the diagnosis with loss of quality or quantity of the muscle. Third is we call it severe when there is a poor functional performance. Further, before we move ahead, I will talk about some of the term which is ambiguous and often used with the sarcopenia. First is malnutrition, which is quoted in older studies, and it is natural to expect malnutrition in liver disease condition as liver is responsible for almost all aspects of nutrition. The problem with malnutrition is it is difficult to quantify and clinically is characterized by loss of fat, muscle as major component of malnutrition. Second, which is often used, is frailty, and it is decline in physiological reserve that leads to increased vulnerability. Sarcopenia is part of the syndrome but not synonym. Third is myosteatosis, which means increased deposition of lipids in the muscle. The fat can be taken up for muscle mass and represents an important bias in evaluation of muscle mass component in the sarcopenia. So, how common is sarcopenia in chronic liver disease? In simple words, I will say very. Sarcopenia is prevalent almost 65 to 90%, 90% in the liver cirrhotic condition, and the severity increases, the sarcopenia increases. So there is more than 10% sarcopenia in child A, more than 34% in child B, and more than 54% in child C. Whereas myosteatosis is more in obese patients, approximately 50%. Frailty is measured by muscle parameters and depends on stage of the disease and reported to be present 30 to 79%. So is sarcopenia relevant in liver cirrhosis condition? Yes, because it predicts poor outcome. It is an independent predictor of adverse conditions such as hepatic encephalopathy, high mortality in both pre and post liver transplant, HCC with the higher treatment risk and complications and mortality, higher frequency of infections following the liver transplant. So impact of MELD score is independent and it may be under prioritized. So till now we do not know why in sarcopenia patients are more susceptible to sepsis. What is the utility of MELD sarcopenia score? So what causes sarcopenia and liver disease? Yes, of course, it is the malnutrition, hyperammonemia, hormonal deficiency, inactivity because inability to exercise, endotoxemia from gut microbiota dysbiosis. So before we go ahead, we have to understand that muscle are very closely related to the liver. Liver talks to the muscle which is well timed, coordinated conversation. If something goes bad in the liver, it is affected to the muscle and vice versa. And they are also interdependent and metabolically related to each other. So liver talks to the muscle through kines, which I will discuss further. Pathogenesis of sarcopenia is very well characterized, that the increase in portal pressure leads to ascites, anorexia, intestinal dysmobility, malabsorption, which leads to protein energy malnutrition, and the cause of inflammation, low testosterone levels, which eventually leads to sarcopenia. Whereas when there is a hepatocyte damage, there is low glycogen storage, low ureanesis, systemic shunting leads to hyperammonic condition, which eventually leads to more of protein degradation in muscle, and hence the state of sarcopenia occur. So to increase the muscle mass, what we need is protein-rich diet, exercise, growth hormone, which regulates the mammalian target of rapamycin complex 1, which is mTORC1. Whenever there is a liver damage, it induces endotoxin and ammonia, which inhibits the protein synthesis by upregulating myostatin 1, which I will discuss in further slides, which is transcription factor from TGF-beta family and other proteolytic conditions. So, which decreases the protein synthesis and increases the protein degradation. So, till now, we always thought that muscle is an organ for the movement. But lately, we have realized that muscles are body's central protein banks. It is a reservoir from which we can draw the protein. The postprandial periods, all the amino acids are converted to muscle protein, and during the fasting, this muscle protein is converted to amino acid for use of other organs. Not only this, muscle is also an endocrine organ, as it produces different kind of kines, which are also myokines, that modulate the systemic physiology and become the mediators of crosstalk of muscles with other organs. So today's topic is myokines in the sarcopenia. For many of you, it is a new term, but don't feel scared. It is also part of the kines world. We've known cytokines from last 50 years, and they were discovered and identified as small proteins as chemical messengers, which are key players in various biological functions, so as adipose tissue and liver also releases such proteins, which are termed as adipokines and hepatokines. But very recently, almost 10 years ago, a subtype of cytokine has been identified, which are released to muscle contraction from the muscle cells, myocytes, and they are termed as myokines. And the receptors of myokines are found on various organs such as heart, liver, pancreas, and other organs, and even on the immune cells. So now there are a lot of research has been going on actively that what these myokines are doing. There are more than 600 myokines which are being identified, but only few has been characterized, and we know the biological function of them. Even their picomolar concentrations are enough to do any physiological function in the body. They can act via autocrine, paracrine, and endocrine modes. And the term myokine was first coined in 2003, which is very recent, and 2008, the first myostatin was identified. And IL-6, we already know which is a cytokine, but it comes in the category of in the myokine because muscles also release IL-6 immediately after the exercise, and it is known as one of the first myokine produced after the exercise in the bloodstream. So there are many names which you already know about myokines, and they are categorized on their type, such as cytokines, growth factors, proteins, hormones, and some are uncategorized. So IL-6, IL-15, IL-8, IL-10 is part of cytokine released from muscle during the muscle contraction. Brain-derived neuronic factor, fibroblast growth factor 21, vascular endothelial cell growth factor, insulin growth factor. They all comes under growth factor category. Myostatin, we will talk about a lot. Follistatin is the one which is released from the liver and it goes to the muscle and crosstalk with the muscle protein degradation. And spark, irisin is also one of the main hormone which is categorized in myokines, and we will talk about their status in liver cirrhosis and sarcopenic condition. So there are two different categories broadly if we categorize them. They are positive regulators and they are negative regulators. Basically the good guys and the bad guys. So myokines are not always bad, they are also good, because irisin, which is a hormone, brain-derived neuronic factor, and decorin, follistatin is all categorized because in a good positive regulator because it induces muscle hypertrophy and it induces satellite cell proliferation in the muscle and also increases protein synthesis. Whereas IL-15, IL-6, they are also involved in mitochondrial metabolism and mitochondrial biogenesis such as myonectin, FGF21. So muscle atrophy, myostatin is the one which is a key player in muscle atrophy, and it degrades the protein in the muscle. Because of it, muscle mass decreases. And also there are some inflammation inducers such as IL-15, IL-10 and IL-8. So first let's talk about myostatin because this was the first myokine to be identified. In 2010 they found that myostatin is a causal pathway of acquired insulin resistance whenever there is a physical inactivity. So in the same time, there was a group by Garcia et al. In 2010 itself. They took 36 end-stage liver disease patients and compared with the healthy controls, and they found there is a more than 4 times myostatin level in their plasma in the liver disease patients with the sarcopenia. And no differences in male and females were found, and no differences in etiology. But the sample size was very less. Again, there's another study which shows that myostatin increases with the increase in the severity. In the cirrhosis from child A to child B to child C, the myostatin level start increasing. And the high level of myostatin is also associated with poor outcome in both with and without HCC group. So next, they also looked for other myokines such as follistatin and irisin. Both follistatin and irisin is involved in myostatin inhibition. So follistatin and irisin, they are involved in satellite cell proliferation and increase in the protein synthesis. So when we see from control to child A to child B and C, the myostatin level with the severity increases. So as the irisin and decreases and follistatin decreases. So irisin is considered as one of the most predictive parameter cirrhosis related mortality, but only for child A patients. Whereas myostatin is a more indicative in child B and C group regardless even of the sarcopenia status. So if there is no sarcopenia, then also it was found that myostatin level increases with the severity of the cirrhotic condition. So a lot of study has been done in the NAFLD, and they have found even in the NAFLD with or without obese condition, the myostatin level is very, very high in the sarcopenic condition. And interestingly, it was found that it is correlated with the collagen proteins such as procollagen 3 and even 6. So there is a direct relation of irisin and myostatin with the collagen. And there's another study which shows that whenever we give in the animal model, in the LPS injury, if we give irisin as a supplement, it decreases the liver enzyme and improves the histology of the liver. So irisin can be directly given, and it has been shown in the animal model, which improves the liver condition. So myostatin, follistatin, and now interleukin-6 is not only limited to the liver cirrhosis, even in the hepatocellular carcinoma condition, they have found in comparison to healthy, the myostatin level increases in HCC patients and follistatin increases, IL-6 increases. So there were almost 56.4% sarcopenic prevalence, but then also these myokines were increased in all the HCC patients, which was directly proportional to the myostatin levels were directly proportional to the SOIS score, which is the muscle score. And IL-6 was indirectly proportional, and follistatin has no association. This was also associated in the resected HCC patients. The myostatin is associated with poor outcome. Follistatin levels is an independent factor for poor survival in the HCC patients. So then not only cirrhosis, even whenever the fibrosis stage increases, the myostatin is increasing with the fibrotic stage. And in fact, in the cell culture system, what they have done, they have taken the LX2, which is a hepatic stellate cell line, and primary fibroblast. When they induce the myostatin, the collagen 1 alpha and all the profibrogenic genes, they start upregulating. So it was shown that myostatin can directly induce the induction of fibrotic genes in the HSC. So this is a very complicated network, but don't feel scared. But this is a very interesting study in Liver International in 2021, where they are finding a multi-omics analysis of gut, liver, muscle. So these all three are interconnected, and they found in 50 cirrhotic patients with sarcopenia, on assessment of gut microbiota, metabolomics, serum myokines, and systemic and intestinal inflammatory mediators, factors which were associated with sarcopenia in cirrhotic patients were interconnected, such as Klebsiella, hand grip strength, FGF21, IL-6, Streptococcus LPS. They all are interconnected network, which is seen here in case of cirrhotic sarcopenia. So this is a network diagram which shows that all these things goes hand in hand. So another factor which they found was FGF21, which is a fibroblast growth factor and liver secreted peptide hormone, but synthesized in liver, pancreas, and skeletal muscle. FGF is also shown that it improves the histological NASH activity with decreased body weight and liver triglycerides. And way back in 2020, they found the mechanism that how FGF21 is working is through hepatocyte TLR4 IL-17 signaling. FGF21 is actually a very unstable in vitro and have a very short half-life. So there is a novel high receptor binding FGF21 analog, which is even in the clinical trial phase 2 for the dual target construct, and provided a beneficial effect in the NAFLD mouse model. So how to maintain the myokines? How we can improve our myokines? The simple answer is contract your muscles and activate your myokines. Exercise is the medicine. So what about the patients? They cannot run, their inability. So the good news is myokines is not about impact. It's about muscle contraction. You contract your muscle, myokines will be released, myostatin will be decreased, irisin, follistatin will increase. So if you even do a simple walking, there is a muscle contraction and myokines will certainly improve. So we have an evidence for this. There was a study in 2018 which showed that comparing myokine levels with resistance training versus high intensity interval training, they found similar effectiveness. And they did the blood serum levels of FGF21, follistatin, and myostatin after 0 hour, 1 hour, 3 hour, 24, 48, and 72 hours. So among the high intensity or the resistance training, there was not significant differences, but it increases within 1 hour or 2 hour. The FGF21, follistatin, and myostatin decreases within 24 hours of the exercise. So myokines, can they act as exercise mimetics? There are multiple studies which have shown that post-exercise, the myostatin level decreases, IL-6 level increases immediately, but it decreases eventually. IGF-1, which is insulin growth factor 1, increases, VEGF-1 increases, follistatin increases. So again, the answer is you exercise, contract your muscle, and improve your myokines. But till date, we do not have a comprehensive study on duration of exercise and time kinetics for the release of various myokines. So till now, exercise is considered to be one of the best remedies for sarcopenia, for end-stage liver disease, because it activates the insulin growth factor and increases the mTOR signaling, downregulates the ubiquitin proteasome pathway. So evidence is it is good in general well-being, it improves muscle mass, ventilatory function, but there is no data on robustness of mortality, but recommended universally. So recommendations by a Mayo Clinic Flexit study, there should be 30 minutes of moderate intensity walking 3 to 4 times per week in combination with resistance training, such as light hand weights thrice a week as tolerated by the patient. So myokines are also in clinical trials. For example, FGF21, which has been associated with non-alcoholic fatty liver disease. This is still active. Irisin levels in obese children, obesity with NAFLD, without NAFLD, it is a independent marker of severity of the disease. And then the myostatin. Myostatin is also involved in malnutrition with portosystemic shunting, and other FGF21 analogs has been in the clinical trials with phase 2 randomized double-blind placebo trial, which is still ongoing, and some are completed. But still we are very far behind a comprehensive understanding of myokines because we have a limited knowledge till date. So treatment of sarcopenia. So thus treatment improves outcome. There is no large randomized controlled trials, so no medications or intervention specifically approved to treat sarcopenia and cirrhosis. So exercise is the one which is known to increase muscle bulk in animal models as well as in humans, and they are shown no mortality benefit, but still it is recommended. So there's one RCT which is going for the testosterone therapy, which is only for the men. They demonstrated a significant improvement in muscle mass with the tend to reduce mortality in the treatment arm. TIPS is, yes, another way. This is a very famous study in which they have treated with TIPS 57 cirrhotic patients, and after TIPS they found that muscle area increased in 41, whereas there was unchanged or decreased in 16 patients. So predictors of reversal of sarcopenia after TIPS included make and lower pre-TIPS muscle area. So liver transplant is not the solution because there are many studies. In fact, one of this is that even after liver transplant, sometimes the sarcopenia increases, which is 15% and a risk factor for the adverse outcomes. So it might be possibly related to the immunosuppressive drugs. So insulin growth factor 1, which is also a myostatin inhibitor, it increases mTOR signaling, but there is no human studies or not recommended RCT. It's still under research protocol. There are other drugs which are myostatin antibodies which are in phase 2, stamulab and domazunab, and mTOR agonists which are still in the very early experimental stages. So we need to find out more clinical trials and go about it. So why does not someone just create a pill for myostatin inhibitor? There is an answer. In 2020 study, it was found that the myostatin, which is mature form, is structurally very similar to TGF family ligands, which may result in a cross-reactivity of myostatin antagonist with other closely related growth factors. So myostatin suppressors are currently too risky. We cannot give myostatin inhibitors directly because it is involved in many other physiological functions. So work at ILBS, we tried to find a solution. So Preeti Negi, me and under Sir's guidance, we are trying to find out if we can use, instead of myostatin inhibitors or myokines, let's use exosomes. So who are new to the exosomes world, this is a small cell-derived vesicles which are released by every cell type, and they carry information like cargoes, like trucks, from one cell to another, and the information can be proteins, miRNA, RNA, or metabolites. So we thought if we cannot give myokines directly, let's give exerkines, which are exercised release exosomes which carry myokines. So the muscle and the liver crosstalks with each other through myokines, but there are evidences which shows that muscle and liver can also crosstalk with these small vesicles. So if we exercise, there will be certain exosomes, which are exosomes carrying myokines, which will go to the muscle and it will improve the muscle mass. So for this study, we have taken 42 of the sarcopenic patients and 20 are without sarcopenia and 11 healthy. So they were a treadmill running for 20 minutes and their peripheral blood was immediately taken after exercise. From the plasma, we isolated the exosomes and exersomes both. So exersome term I am using after the exercise, the exosomes are released. We are using this term exersomes. So the myostatin, IL-6 and follistatin was measured, and also we have done some proteomics to understand what kind of proteins are released after exercise in healthy versus sarcopenia or non-sarcopenic cirrhotic patients. So this is very interesting. It is only in the exosomes. If you look at the pre is the red, post is the blue. This is the healthy, cirrhosis without sarcopenia, cirrhosis with sarcopenia. And we have found a significant reduction in myostatin in sarcopenic patients from pre to post exercise. Follistatin level increases and IL-6 level decreases. So the bad guy in the sarcopenia after exercise in the exosomes actually decreased. And the follistatin, we found a significant increase, and the inflammatory IL-6 was found to be decreased. Upon the proteomics from these exosomes, pre and post, if you see these clusters, they are the patients healthy. This is non-sarcopenia and this is sarcopenia. Here also this is healthy, non-sarcopenia and sarcopenia. So if you see the clusters, they are differentially segregated in the pre-exercise condition, whereas in post, at least sarcopenic and non-sarcopenic had many overlapping conditions, which shows that if we make sarcopenic patients exercise, it might help them to induce certain proteins which will be beneficial in nature. So what proteins we got? In healthy, we got insulin-like growth factor, which was upregulated, and trypsin 1,3 stromatin. In non-sarcopenia, only some immunoglobulins, which is immune regulator. In sarcopenic, we found tropomyosin, which induces muscle contraction, and vascular cell adhesion protein. So there were many proteins, but I am quoting only the ones which has more than 10-fold increase. So sarcopenic has some effect of the exercise which will be beneficial. So not only this, what we have done is made the some healthy mice exercise, took their exosomes and put them in the CBDL mouse model, which is a liver damage model, and we administered them after 2 weeks, and after every 2 weeks we've given the exosomes to them. And interestingly, what we have found, after giving the resting EVs and the exercised EV, the liver enzyme, the blue bar are the exercised EV, the liver enzyme decline after 2 weeks of injections of exercised EV, and so as their liver pathology improved. Muscle mass, there was not much difference, but we found a betterment in the liver enzyme. The whole liver, the body weight, there was a decline. So to summarize my talk, myokines are key players in the development of sarcopenia in the liver disease setting. Myostatin, irisin are independent predictor of severity of liver cirrhosis and poor outcome. Myokines also induces fibrosis and progression of the liver disease. Exercise is safe, effective, and recommended medicine to improve myokine levels in liver cirrhosis patients with sarcopenia. Exercises decrease the myostatin levels, as in our study, and increase follistatin level in exosomes and plasma. In healthy, insulin growth factor was upregulated post-exercise, whereas in sarcopenia, the tropomyosin, which induces muscle contraction. Exosomes carry myokines and has the potential to improve the liver damage. And the detection of myokines in exosomes opens a new vista of muscle-liver axis. Thank you for your attention.